Hello and welcome back to Count to 10. In today's episode, we're going to cover VQ relationships. This is a colossal respiratory topic, and in this podcast, we're going to talk about the vertical gradient of pleural pressure, all the way to talking about dead space, shunt, the shunt equation, looking at how you measure VQ relationships, and then as always, looking at the past SAQs, of which there are heaps in the ANZCA exam. Each learning objective in this topic has been asked in one way or another as an opening statement in a Viva, and it's a must-know, just like every other respiratory physiology topic we've covered so far. What I think makes VQ relationships different is that if you understand this topic well, it actually bodes well to your clinical knowledge. It's something that you can apply every day, from the time when you put an obese patient to sleep and you notice their SATs dropping, or when you notice a patient is hypotensive and you see their end-tidal CO2 decreasing. All these changes are occurring due to VQ relationships. So this topic is at the core of what we do day to day. With that said, I'm going to try to keep this podcast within the 1 hour mark. So let's dive straight in.
1, 2, 3, 4.
Our first learning objective is explain the vertical gradient of pleural pressure and its significance. Now, this isn't a hard concept to understand. It just requires you to remember our compliance curve and how that compliance curve shows hysteresis. Now, we know that regional differences in ventilation exist in the lung, and we know this because it's been shown by radioactive xenon. Ventilation per unit volume has shown to be greater in the base of the lung compared to the apex when you're in a standing position. And the reason for this is pretty simple. Remember, the intrapleural pressure is the pressure within the pleural cavity, and typically we quote this as -5 millimeters of mercury. However, we know that this intrapleural pressure, or the number we quote, isn't equal throughout the whole lung. In certain areas of the lung, this will be more negative, and in other areas, this will be less negative, and this is what causes regional differences. If we have a person standing up, we say that the weight of the lung in the upright position causes less negative intrapleural pressure at the base compared to the apex. And this is simply because anything that is supported requires larger pressures below it than above it. To understand this, if you just take yourself as an example, when you're standing up, you're supported by your legs and your feet. The pressure at your feet is going to be higher than the pressure, say, at your waist or your shoulders. In the same way, when we're standing up, the pressure at the base of the lungs is going to be higher than the pressure at the apex of the lung. So how does this create a regional difference in ventilation? We've said that the intrapleural pressure is negative. So if we get a higher positive pressure at the base, the intrapleural pressure is going to become less negative, while at the apex, it will become more negative. So typically, what we say is at the base, the intrapleural pressure, negative 2.5 centimeters of water. And at the apex, the intrapleural pressure is going to be negative 10 centimeters of water. Now, when we plot this on the compliance curve, remember the compliance curve on the x-axis has intrapleural pressure, and on the y-axis has the volume of the lung. Because compliance is defined as the change in volume over change in pressure, we can draw the compliance of the lung, which is a typical sigmoid shape which displays hysteresis because of the time-dependent behaviors of the lung. We can then plot the 2 points, the apex and the base, on the curve. What we see is that the apex is at the flat upper portion of the curve. So at this point, the alveoli are already well expanded, their volume is high, however, they don't have any further room to increase the volume further for any increase in pressure. The base, on the other hand, lies on the steep part of the sigmoid curve, where the volume is lower, however, for any small change in pressure, their volume can increase dramatically. And that is why we say, at the base, for any given change in pressure, we get a large change in volume, while at the apex of your lung, for any given change in pressure, you only get a small change in volume. And that's the reason why ventilation is better at the lung base compared to the apex. So it's all really about which part of the lung sits on that steep part of your compliance curve. When you're standing and awake, it's the base. However, when you're anesthetized and supine, we get a decrease in our FRC, and now all of a sudden, the part of your lung that lies on the steep part, our anterior, remember we're lying supine, and our non-dependent part of the lung lies on the steep part. So this is the area which will have the biggest change in volume for a change in pressure, and therefore can be said to be the best ventilated. Commonly in the SAQs, we get asked, how does the ventilation and perfusion match when we're standing up? How does that change when we lie down supine and become anesthetized? And how does that change when we go into a lateral position? So a fundamental understanding of which part of the lung lies on the steep part of the compliance curve will be able to tell you which is the area of the lung which is getting the best ventilation. Now the next learning objective is describe closing capacity and its relationship to airway closure and explain its significance and measurement. Everybody loves closing capacity. It's a constant favorite Viva topic. Funny enough, it's never been asked as an SAQ in the ANZCA exam, but has been asked in the KICM exam. The easiest way to define closing capacity would be to say it's the residual volume plus the closing volume. However, the more technical way to define it would be to say it's the maximum lung volume at which airway closure can be detected in the dependent parts of the lung. The simple way to understand that definition is just to say it's the point where lung volumes fall enough for small airways to collapse. Now, why is closing capacity so important? Essentially, if you imagine that the lung, or more so the alveoli, are pulled open by the traction of other neighboring alveoli and the alveoli septa near it. When you expire, that traction decreases as the alveolar volume decreases. At this stage, the small airways decrease in diameter, and the closing capacity is the lung volume at which these small airways start to close. Because the airways are more squashed together at the dependent regions of the lung, they're more likely and more prone to collapse. Normally, our FRC is larger than our closing capacity. So with normal tidal volume breathing, we're not getting to the point where we're getting airway closure with every breath. However, when our FRC drops below our closing capacity, so our closing capacity is higher, then we run into issues where with every breath, we're going to have some degree of small airway closure. So some degree of small airway closure is going to lead to some degree of airway collapse. These areas where the airway or the alveoli are collapsed are no longer able to participate in gas exchange, and therefore is a significant cause of a VQ inequality. There are many factors that can change closing capacity. Typically, we remember age as the most important, and that's the graph that we refer to that we'll talk about in a second, but it's not the only factor. So deranged physiology has a great list of factors, and within that list, we have expiratory airflow. When we increase our expiratory airflow, we can almost double closing capacity when our flow goes from 30 liters per minute to 60 liters per minute. And this is simply because we're causing a greater loss of that traction holding the small airways open. In the same way, if we increase our expiratory effort, our intrapleural pressure might increase and cause airway closure as well. So two causes of increasing closing capacity are increased expiratory airflow and increased expiratory effort. The other factors are small airway disease. So here we're getting a loss of the elastic recoil that provides the traction, and therefore the airway starts to close at a high lung volume and air trapping occurs. Another factor is increasing our pulmonary blood volume. The weight of the extra blood puts pressure on the dependent lung, and this causes them to collapse at high lung volumes. We also have the effect of decreasing surfactant, which increases the propensity of airways to collapse. And then finally, we have the effect of age. This is the diagram that you'll commonly be shown in a Viva setting. The effect of age on closing capacity is largely thought to be due to a deteriorating lung elasticity and a loss of the stretch recoil, as well as an increase in residual volume, leading to an increase in overall closing capacity. So this diagram will have on the x-axis age, and on the y-axis it'll have total lung capacity. Depending on where you search, some of these diagrams will start at 20 years, some of them will start at 0 years. The important thing to realize is that when the graph starts at 0 years, the closing capacity when we're initially born as a neonate is higher than the FRC. The importance of this with a neonate is that with every tidal volume breath, they're getting some degree of airway closure, and when we give them a general anesthetic and decrease the FRC further, we're going to cause this gap between FRC and closing capacity to increase even further, and then we're going to get a massive VQ inequality occurring. By 6 years of age, the closing capacity reaches its lowest point on the graph, so it's the furthest distance away from the FRC, so the biggest gap, and from that 6-year mark it has a linear increase where it slowly gradually goes up and gets past the FRC mark. The two important points where closing capacity overcomes FRC after 6 years is in a 45-year-old human in the supine position and in a 65-year-old human in the erect position. So if you're asked in a viva setting at which points in this diagram are closing capacity higher than FRC, you would say at birth as a neonate, at 45 years old in the supine position, and at 65 years old in the erect position. And this is common knowledge that you must know. The clinical significance of closing capacity we've already discussed, but it's an area of the lung that isn't going to be able to participate in preoxygenation because it's not receiving any fresh oxygen. It's an area of the lung at which there's atelectasis, so there is a VQ mismatch, and importantly there is a shunt, and a shunt can't be improved once it gets to a certain point by giving the patient more and more oxygen. And the other thing is that it actually aggravates the lung, causing injury. If you imagine those small airways are collapsing and shearing against each other by constantly opening and closing, there's going to be a degree of biotrauma that's going to be associated with that. So closing capacity is something that you must always be mindful of with every patient that you anesthetize. How do you measure closing capacity? Well, there's two ways. There's the gas bolus measurement technique, or there's the resident gas method. The resident gas method is far most common and the one that you'll be shown in a viva setting, so that's the one I will discuss. This technique is really simple, and essentially what you do is you get a patient to breathe room air. They have a max expiration to residual volume, followed by a max inspiration with 100% oxygen, and then a subsequent slow expiration to residual volume. You measure that expiration and, more importantly, the nitrogen content that's been expired out with that slow expiration. We plot that on a graph which has lung volume on the x-axis and the nitrogen concentration on the y-axis. And this graph gives you 4 distinct phases. The first phase is the pure dead space, where there's no nitrogen at all. The second phase is a mixture of dead space and alveolar gas, so you get a rising concentration of the nitrogen. The third phase is the pure alveolar gas, so this is where you get a plateau nitrogen concentration. Then finally you have the fourth phase, which is where you start to get the dependent alveoli closure. And here, the poorly ventilated alveoli empty, and because they were poorly ventilated, they never got that fresh oxygen on inspiration, so their nitrogen concentration remained higher, so you get an uprise of our nitrogen concentration graph. That point of rise represents the dependent alveolar closure as mentioned, and it represents the start of closing volume. So from there until full expiration is your closing volume. It's not your closing capacity. That needs to be measured with closing volume plus your residual volume. So you need to do another test to figure out what your residual volume is. You add that onto your closing volume, and then you get a closing capacity. That's a common little sneaky point that examiners love you to know when they're asking about this graph, just so you can demonstrate your understanding of how to test for closing capacity. The next learning objective is discuss dead space, its measurement, and apply the Bohr equation and the alveolar gas equation. We'll combine this learning objective with describing the west zones of the lung, because I think it nicely fits in. The best way to describe dead space is just to say that it's wasted ventilation. It's the areas of the lung that receive ventilation but no blood flow, so therefore they can't take part in gas exchange. There are 4 different types of dead space. There's anatomical. So this is the volume in the conducting airways, which in an adult is around about 150 mils. There's the alveolar dead space. So this is dead space that goes past the conducting zone into the respiratory zone but receives no perfusion. And commonly this occurs in West Zone 1. Then you have physiological dead space, which is just alveolar plus anatomical. And then finally we have apparatus dead space. So this is part of the breathing circuit where there can be gas mixing occurring. So typically we say that this is the part of the circuit past the point of the Y connector. If we think about each of the types of dead space, we can think about factors that affect each one. So in terms of anatomical dead space, we can say this can be affected by a patient's body size and age. Typically an infant has a higher amount of anatomical dead space, 3 mils per kilo, compared to an adult, which is approximately 2 mils per kilo. On the same line, our posture and our movement of our head and neck affect our anatomical dead space. So when we're standing up, when we're looking up and our neck is extended, our anatomical dead space is going to be increased because we're stretching our upper airways and our trachea and our conducting zones. When we're shriveled down and hunched over, the anatomical dead space is going to be decreased. Also, when we're taking a large breath and increasing our lung volume, we're going to be increasing the area within our conducting zone. So a larger lung volume is going to be associated with a higher anatomical dead space. And the way we breathe will also affect our anatomical dead space. So if we take small tidal volumes and slow our rest rate down, we're going to be increase the propensity to generate laminar flow. We're going to be improving our flow and decreasing the resistance to that flow, which means more flow is going into that respiratory zone and we're decreasing our total anatomical dead space. We can also use drugs to manipulate our anatomical dead space. So bronchodilators like salbutamol will increase our anatomical dead space by increasing the total volume of the conducting airway. The factors that affect alveolar dead space can be best described using the West Zone. West Zones describe how there's inequality in blood flow in an upright lung. And this is because blood flow in an upright lung will decrease linearly from the top down to the bottom. And that's caused by the effects of hydrostatic pressure. The West Zones describe the relationship between blood pressure in the arterial circulation, blood pressure in the venous circulation, and the alveolar pressure itself. There are 4 West Zones in total. The first West Zone is at the apex of the lung. And remember, in healthy people, this is a very minimal zone and it doesn't even really exist. In this zone, we say that the alveolar pressure is higher than both the arterial and the venous pressure. In this zone, the capillaries in between the alveolar are squished because of the high pressure, so no flow can go through this. And because there's no perfusion, but there is ventilation, this is alveolar dead space. The factors that make this zone bigger are things like low cardiac output states like shock or a cardiac arrest, a PE which blocks the path of any blood flow going into that area, having high positive pressure ventilation, which is increasing that alveolar pressure even further, posture and positioning. So if you lie the patient supine, you're kind of getting rid of that hydrostatic gradient. So now the hydrostatic gradient is more anterior to posterior rather than being superior to inferior. Parenchymal disease like emphysema will destroy the alveolar septa so that flow can't get in. So these are all causes that can increase West Zone 1 and therefore increase alveolar dead space. Now to complete our discussion on West Zones, our next West Zone is West Zone 2, and this is said to be from the apex of the lungs to 10 centimeters above the heart. Here, our flow is governed by our alveolar pressure and our arterial pressure. Depending on the respiratory cycle, our alveolar pressure can be higher than our arterial pressure, at which point there's no flow occurring, or our arterial pressure can be higher than our alveolar pressure, at which point flow does occur. The reason for this is when there is inspiration, our alveolar pressures increase. At this point, they are higher than our arterial pressures. In our capillaries in this zone, the blood is building up, leading to a high generation of pressures. As that pressure starts to build up and then exceed our alveolar pressure, blood flow occurs, and then the pressure drops again below the alveolar pressure and the flow ceases until the cycle is repeated and repeated. The important part with this zone is that unlike normal flow conventions, where flow is determined by arterial minus venous pressure, flow here is determined by arterial minus alveolar pressure. This is called the Starling resistor effect or the waterfall effect, and it describes how flow is independent of the downstream pressure. Because of the Starling resistor being the alveolar pressure, flow here is occurring at a constant rate. Now we'll discuss the Starling resistor again when we talk about cardiac physiology, and specifically when we talk about guidance curves. For now, just know the concept and that it is a keyword that gets brought up in few different situations. Moving on, our next zone is zone 3, and this is said to be from the 10 centimeters above the heart all the way to the base of the lung. Here we have the restoration of the normal flow gradient, so where our arterial pressure and our venous pressure are both higher than our alveolar pressure, so therefore flow is governed by our normal principles of arterial minus venous difference. Finally, the last zone is zone 4, and this occurs at the base of the lung in the dependent regions of the lung. It has nothing to do with alveolar vessels in between the alveoli, but all to do with the extra-alveolar vessels. So here we get reduced blood flow due to narrowing of those extra-alveolar vessels caused by lung around these vessels being poorly inflated. So this area relies heavily on the radial traction that the lung provides at high volumes to keep those extra-alveoli open. As that radial traction decreases, those extra alveolar vessels collapse, and this is where we get West Zone 4. So just to recap West Zone quickly, we have West Zone 1, which is where we have alveolar dead space, and our alveolar pressure is greater than our arterial and our venous pressure. We have West Zone 2, where our arterial pressure is greater than our alveolar pressure, but that depends on the respiratory cycle. Then we have West Zone 3, where we have our conventional way where our arterial pressure and our venous pressure are higher than our alveolar pressure. And then finally we have West Zone 4, which is all about extra alveolar vessels being collapsed due to decrease in lung traction at low lung volumes. Going back and talking about dead space, so we've already spoken about the factors that affect anatomical and alveolar dead space. The factors that affect apparatus dead space is going to be anything part of your breathing circuit which can have gas exchange occurring. So past your Y connector, like your HME filter, your licorice stick, your ETT, your trachea, are all factors that contribute to apparatus dead space. The ETT is a funny one because technically it increases your apparatus dead space, but because it bypasses a large majority of your anatomical dead space, it decreases the total anatomical dead space. What's the reason we care so much about dead space? Because it's wasted ventilation, you're not getting oxygen transfer, but you're also not getting CO2 transfer. In this area, we get CO2 buildup occurring because we can't get the CO2 out of our body. As our partial pressures of arterial CO2 increase, we then start to increase our minute ventilation by activation of our chemoreceptors. This results in increased work of breathing. To try and compensate, the increased partial pressure of CO2 leads to the activation of the sympathetic nervous system. So now we're wasting more energy, again increasing to our total body work. We're getting acidosis occurring. Eventually, with high levels of hypercapnia, we can get depression of our central nervous system, but also we can get hypoxemia occurring. And the reason why this occurs is we just have to go back to our alveolar gas equation. So now with high dead space, we get increased work and energy consumption, we get hypoxemia, and we get acidosis, all of which can be a lethal combination. The final thing with this learning objective is to discuss ways of measuring dead space. There's really two ways you can measure dead space. You can measure anatomical dead space using Fowler's method, or we can measure physiological dead space using the Bohr method. The Fowler's method is very similar to the way that we measured closing capacity. We're just getting a graph which has nitrogen concentration on the y-axis, and on the x-axis we have the expired volume in liters. We spoke about those 4 phases in this graph, but here we're only interested in phase 2. This is the area where there's a rise in the nitrogen concentration prior to the plateau, and it represents a mixture of both anatomical dead space and alveolar dead space. The point at which in this graph in phase 2, where the areas under the curve are equal, represents the transition from going to anatomical into alveolar gas. The Bohr's method, which is really the Bohr's equation, calculates the physiological dead space over the tidal volume as a proportion or a fraction. The equation is the partial pressure of alveolar CO2 minus the partial pressure of a mixed expired CO2 divided by the partial pressure of alveolar CO2. Now it's really hard to get an accurate reading of alveolar partial pressure of CO2. So what we do with this equation is that we apply an Anchov modification. An Anchov modification allows us to substitute in arterial partial pressure of CO2, and the theory is that we can use this because it represents all of the lung units. However, the caveat is, using the Anchov modification, the result you get is slightly larger than what you have with the original Bohr equation, because arterial partial pressure of CO2 will not only be affected by dead space, it'll be affected by an intrapulmonary shunt, it'll be affected by diffusion impairments, and it'll be affected by normal VQ heterogeneity within the lung itself. The other caveat in this equation is that we're using mixed expired partial pressure of CO2. This is not the same as end-tidal partial pressure of CO2. The way you get mixed expired is that you get the total CO2 content of an expired breath and you divide it by the tidal volume. And people would do this in ICU when they would historically attach a Douglas bag which would capture all the expired gases from a patient, which could then be analysed to figure out what the CO2 content was. Now that's a little side note, but essentially when we're getting back to the Anchov modification, when you calculate it all through, the physiological dead space should be very close to the anatomical dead space in a healthy person. And the way you isolate alveolar dead space is essentially taking that physiological dead space and taking it away from the anatomical dead space. Now our next LO is describe the shunt equation. Just like we said dead space was wasted ventilation, a shunt is wasted perfusion. A shunt refers to the blood that enters the arterial system without passing through ventilated areas of the lung. There's a common term that's associated with a shunt, and that is venous admixture. Everyone loves a crisp, easy definition of a venous admixture in a viva setting. Venous admixture is describing the amount of mixed venous blood. Remember, mixed venous blood is the blood that gets into the pulmonary artery that will typically have a partial pressure of oxygen of 40 and a partial pressure of CO2 of 45. So it's the amount of mixed venous blood that needs to be added to pulmonary and capillary blood to produce the observed difference between arterial, pulmonary and capillary partial pressure of O2. So essentially a venous admixture is saying how much mixed venous blood do we need to put in to equate for the difference we see in the partial pressure of O2 in the pulmonary and capillary blood, which we expect to be 100 millimeters of mercury, and the difference between that and our arterial partial pressure of O2. The important thing is that venous admixture is not an actual amount of venous blood that you can just mingle in with the arterial blood. It's a theoretical calculated amount that would be required to create the observed difference seen between pulmonary and capillary partial pressure of O2 and arterial partial pressure of O2. So it's a theoretical amount. So what forms this venous admixture? Venous admixture actually encompasses all types of shunts, as well as any blood from the alveoli that isn't receiving a VQ relationship of 1. So where ventilation and perfusion isn't equally matched is part of a venous admixture. So with regards to shunt, the two main anatomical causes of shunt are the bronchial veins, which drain into the pulmonary veins directly, and this equates to 1% of our cardiac output, and artesian veins that drain directly into the left side of the heart, which is 0.3% of the cardiac output. So our anatomical shunt is 1.3%, 1% being bronchial veins and 0.3% being the Thebesian veins. These are actually important numbers to remember. You can have other causes of anatomical shunt as well. So in people that have pathology like an AV malformation or congenital heart disease, their shunt amount will be much higher. The other form of venous admixture, being anything that has a VQ ratio less than 1, can be from physiological causes, simply because of the way the gravity affects blood flow and ventilation, which we'll talk about in our next learning objective. Or it can be due to pathological reasons, like when we have atelectasis, a pneumothorax, a pleural effusion, or COPD. And the way that we calculate the total amount of venous admixture, so the amount of shunt and the amount that's VQ less than 1, is really counterintuitive. We use a shunt equation. So just to make this clear, venous admixture encompasses shunt and any part of your lung, so where the VQ is less than 1. The way you figure out venous admixture is using a shunt equation, which is actually calculating venous admixture and not shunt. And the shunt equation itself is a ratio, so it's the amount of shunted blood flow divided by the total cardiac output, and this is equal to, on the numerator, the O2 content of pulmonary and capillary blood, which you can be asked in a viva setting, how do you actually calculate that? And you would say you can calculate that using a couple of different methods. You can calculate that using your ideal alveolar PO2, which is calculated using your alveolar gas equation and your oxygen dissociation curve. It can also be calculated using pre-filled tables, which are in nuns, and both of those answers would be adequate. So once you have the O2 content of pulmonary and capillary blood, you minus it from the O2 content of arterial blood, which you just simply get using an ABG. So that's your numerator. And then on the denominator, you again have your O2 content of pulmonary and capillary blood. You minus this from your O2 content of mixed venous blood, and you get a mixed venous blood sample using a pulmonary artery catheter, which you can get by putting a Swan-Ganz in. Now, like every equation, this equation has its limitations, and you might also be asked that. So the shunt equation assumes that the shunted blood has the same O2 content as mixed venous blood. Now, this may or may not be true. It depends on the O2 consumption. For example, the bronchial circulation and the Thebizian veins might have a different amount of O2 content. The other assumption is that the pulmonary and capillary blood comes from alveoli with normal VQ units, so where the VQ unit is equal to 1. The answer you get from a shunt equation is a fraction or a percentage, and the most important thing about the answer from the shunt equation is its clinical significance. If a person's shunt fraction is too much, no amount of hypoxemia can be abolished by just giving the person 100% oxygen. And there are these graphs in West that depict this. They say that when a shunt fraction starts to become above 30%, the partial pressure of arterial O2 will not be able to be increased despite giving a person 100% oxygen. And there's a couple of reasons for this, but the most important reason is the shape of the ODC. Remember, in the ODC of oxygen, we have the flat upper portion. A small depression in the arterial O2 concentration causes a large decrease in the arterial partial pressure of oxygen because of that flat upper part. So even when we get a small amount of shunt occurring, we notice a big effect on the arterial partial pressure of O2. This is in contrast to the effect that a shunt has on the partial pressure of CO2. As soon as we get a buildup of our arterial partial pressure of CO2, our chemoreceptors get activated and our minute ventilation increases. Due to the shape of the CO2 dissociation curve, because of its linear shape, any slight change in arterial CO2 content produces a very little change in the partial pressure of arterial CO2. So clinically, we can use this knowledge and draw some conclusions. When we're analyzing an ABG, we can say that the arterial partial pressure of O2 is a very useful marker as a blood gas measurement tool to see or detect venous admixture. And I think this is a good segue into talking about normal VQ matching and regional differences in VQ inequality. Now, we've kind of already discussed the normal ventilation perfusion matching, and if you can imagine that VQ is a ratio, ideally we want ventilation to be exactly matched to perfusion, so we want this ratio to be 1. But we know that the lung itself will not be ideal, and then there'll be areas of inequality because we know that dead space and shunt exist. Because of this, we say that a normal VQ in our lung is approximately 0.8. While being 0.8, it's still 95 to 97% efficient at exchanging V and Q. So our lung as a whole is a very efficient system for ventilation perfusion matching. We can look at VQ further and say there's a spectrum of VQ matching. If we say on that spectrum that 0 is one end and infinity is the other end, in areas where the VQ is less than 1, this will resemble closely to that of mixed venous blood, in the sense that the partial pressure of oxygen will be lower than the ideal partial pressure of oxygen, which is 100, and our partial pressure of carbon dioxide will be closer to that of mixed venous blood at approximately 45. In VQ areas which are greater than 1, this will closely resemble that of the composition of the inspired gas. So remember, our inspired O2 has a partial pressure of 150 after it gets warmed up by humidification. Because in these areas there's not much CO2, there's not much dilution of that partial pressure of O2. So in areas where VQ is greater than 1, the partial pressure of oxygen will get close to 150, while the partial pressure of CO2 will get close to 0. And our lung sits at that normal VQ range of 0.8, where our partial pressure of O2 is 100 and our partial pressure of CO2 is 40. So that's the first part about understanding VQ when we talk about understanding VQ in the context of dead space and a shunt. The second part of understanding VQ is in the context of regional differences. We've kind of already alluded to this previously by saying that we know that blood flow through the lung is highly dependent on the hydrostatic pressure created by gravity. And we also said that the ventilation is better at the base of the lung compared to at the top of the lung because of the shape of the compliance curve and where the alveoli sit on there. So then we can combine this and say that both ventilation and perfusion increase from the apex to the base of an erect lung. However, the increase is not exactly the same. The increase in ventilation as we go to the base is less so than the increase in perfusion. And the reason is quite simple. It's simply because the pulmonary circulation is a low pressure system which is more affected by the effects of gravity. So perfusion increases much more as we go from the apex to the base comparatively to ventilation. And this creates the regional differences that we allude to in VQ matching in a normal lung. You will also find this classic diagram in West where on the x-axis you have at one side the base of the lung, on the other side you have the apex, and you have two y-axes. On the left-hand side you have flow, on the right-hand side you have VQ. Both the ventilation and perfusion lines increase as they get closer to the base, and the VQ ratio increases as it gets closer to the apex. The important point on this graph is rib 3, because this is where VQ are equal, so the VQ ratio is 1. And the other important point on this graph is knowing what the VQ ratio is at the apex and the base. So at the apex the VQ is 3.3, at the base it's 0.63. The partial pressure of oxygen at the apex is 132, while at the base it's 89. The partial pressure of CO2 is 28 at the apex and at the base it's 42. And the pH at the apex is 7.51, while at the base it's 7.39. So a couple of important things from those differences. The first one is that you'll notice that the difference between the partial pressure of O2 at the apex to the base is 40, while the difference in the partial pressure of CO2 is only 15. And the reason why the CO2 difference is so small is because it's more closely related to ventilation and minute ventilation. Now this graph in West will change depending on a patient's position. This is described as an erect patient, but when they're supine, the VQ relationships will change because the effects of gravity will change. Also in normal physiological states like exercise will increase our blood flow and increase our ventilation where we get improved VQ matching. There are also intrinsic mechanisms like hypoxic pulmonary vasoconstriction that will be activated to help improve VQ matching. And the most important thing when it comes to regional differences in VQ relationships is remembering that O2 compared to CO2 has marked differences. Because of the linear shape of the CO2's dissociation curve, it can compensate better for regional changes, while because of the sigmoid shape of the oxygen curve, it is less efficient at compensating. More blood passes through the low VQ areas, which are at the base of the lung, than the high VQ areas that are at the apex. While you would think the high VQ areas and the low VQ areas would cancel each other out and compensate, they do not. And this is because the ODC is non-linear and raises in the oxygen do not lead to a high increase in the oxygen concentration because of the flat upper portion of the curve. Now the final learning objective is outline methods used to measure VQ inequalities. Simply put, you can divide these into measurement techniques that are qualitative or quantitative. Within qualitative, we can talk about things like an AA gradient assessment. We can do lung scans with radioisotopes, where a patient inhales a radioactive gas such as xenon, which is not too soluble in blood. You can do non-invasive techniques, like a vibration response imaging or an electrical impedance technique. But really, if you were to be asked this, you'd be asked about quantitative assessments. And we've already talked about these. We've talked about the Shunt equation. We've talked about the Bohr equation with the Anchov modification. And the only other new one to add is the multiple inert gas elimination technique, or I call it a MIGIT. Technically, this is a really hard test to do and usually only done for research. You have 6 tracer gas, all with different blood gas solubilities, which range from being very soluble to very insoluble. They're all dissolved with saline and then given IV as an infusion. When they reach a steady state, a mixed venous blood sample and an ABG sample are taken, and then you get the results plotted on a VQ ratio graph. A VQ ratio graph on the x-axis has the VQ ratio, and on the y-axis has the VQ blood flow in liters per minute. What you'll get is one trace that depicts ventilation and another trace that depicts perfusion. You want those two to be as close to each other as possible. They're not going to be exactly overlapping because remember the normal VQ of the lung is 0.8. But if you have wide spaces between those lines, they can indicate things like dead space, shunt, pathologies such as emphysema, asthma in patients, and the response to treatment. So it's actually quite a nice tool, and I do recommend just looking at it once because it could come up as an MCQ. So this finishes up our learning objectives. Now we'll move on to some SAQs. The first SAQ was from 2015 in the ANZCA exam when it was asked, what effect does placing a patient in the right lateral position have on lung ventilation and perfusion? This question is very similar to the most recent ANZCA exam in 2022 first sitting when we were asked compare and contrast the effects of the right lateral position, right side down, on lung ventilation and perfusion in a healthy 70 kilo patient who is awake breathing spontaneously and who is anesthetized, paralyzed with IPPV. Both these questions share similarities in the sense that they're asking your understanding of ventilation, perfusion, compliance, and changes in FRC. An important point from the examiner report was that in a spontaneously breathing patient who goes in a lateral position, that dependent lung actually increases its ventilation and perfusion matching by 10%. The other important point from the examiner report is that dependent lung also now becomes West Zone 3, while the non-dependent lung region becomes West Zone 2. The key domains you want to answer in both of these questions is you really want to talk about ventilation during spontaneous breathing, perfusion during spontaneous breathing, and then both of these concepts during IPPV. You can get extra credit by going beyond simply stating just facts, such as giving the extra effects when the patient is paralyzed, what happens in an open chest, how does hypoxic pulmonary vasoconstriction come into play, how do time constants in the lungs change. But the real key to answering this question accurately comes from answering what the question is asking and drawing your graph accurately. This is probably one of those questions where I would draw a graph, and I did draw a graph in my exam. So to start answering this question, I would have some basic fluffy statements, such as ventilation in the lung is determined by regional differences in respect to the compliance curve, which is sigmoid shape, and that perfusion in the lung is dependent on the hydrostatic forces of gravity. Normally, in an upright lung where spontaneous breathing is occurring, both ventilation and perfusion increase from the apex down to the base. You can then draw that classical diagram if you have time, but the more important diagram that you want to draw is your compliance curve diagram. What you really want to highlight on that compliance curve is that in the right lateral position, so the right side down is the dependent lung. Here, this is the lung that's lying on the steep portion of your compliance curve, so it's going to have much better ventilation than your non-dependent side. With regards to your perfusion, because you're lying right lateral, the hydrostatic gradient is going to go anterior to posterior. So what that means is it's going to go from the non-dependent lung down to the dependent lung. So perfusion is going to be increased in your dependent lung. Because your dependent lung is lying on that steep portion of the compliance curve with perfusion increased, your VQ matching is going to be increased by 10% in the spontaneously breathing patient. However, when the patient is anesthetized with IPPV, you get a decrease of your FRC because the patient is anesthetized. Now, that dependent lung is lying on the flat bottom portion of your compliance curve. It's not going to be in the ideal part. Your non-dependent lung is going to be lying in your steep part. So now you get a mismatch of where your best ventilation and your best perfusion is increasing. So you get VQ mismatching occurring. Additionally, you can bring in those extra points that are unique to a patient being anesthetized. Firstly, you can say that with the anesthetic, your hypoxic pulmonary vasoconstriction response is going to be blunted, which is going to further exacerbate your VQ mismatching. And secondly, IPPV decreases venous return, which decreases pulmonary artery pressure, so it increases more of West Zone 1 occurring. Because West Zone 1 is dead space, there's no gas exchange occurring, further exacerbating VQ mismatch. If you had extra time, you could talk further about the effects of an open chest or one lung ventilation, but really the key to this question is making sure you importantly address ventilation, perfusion, the compliance curve, and FRC. The next SAQ is from the ICU exam, and it was asked in 2019, and it was based on closing capacity. The reason I bring this SAQ up is because the ANZCA exam is just dying to ask this, given how many times they asked about closing capacity in the Viva setting. So the SAQ was define closing capacity, which was 10% of the mark, describe the factors that alter it, which was 30% of the mark, the clinical significance, another 30%, and one method of measuring, which was the last 30%. This is a pretty straightforward question if you know the factors well. So you would just start off by saying closing capacity is the residual volume plus the closing volume. It can also be defined as the maximum lung volume at which airway closure can be detected in the dependent parts of the lung. And then the factors that affect closing capacity are expiratory flow, expiratory effort. So any increase in flow or effort will increase our closing capacity because now we're increasing our propensity of small airway closure. Along the line, small airway disease like asthma, COPD will increase our closing capacity because these are diseases that are having airway narrowing, or they're diseases that are destroying the elastin or the traction of our small airways. So they're increasing the risk of collapse with expiration. Having increasing pulmonary venous flow will be another factor that increases our closing capacity, simply because the weight of the extra blood puts extra pressure on the dependent regions of the lung, causing the small airways to collapse. Having decreasing surfactant will increase our risk of closing capacity increasing. And then finally, age is a linear relationship. Remember we said that there was 3 points in our age diagram where closing capacity is higher than FRC. This is when we're neonates, when we're 45 years old supine, or when we're 65 years old erect. The clinical significance of closing capacity is that it increases the risk of small airway closures and gas trapping occurring, which then leads to atelectasis and increases the risk of VQ mismatching. If our closing capacity is higher than our FRC, now with normal tidal volume breathing, we're getting small airway closure, we're getting inefficient gas exchange, and we're increasing our work of breathing. The way we can measure our closing capacity is using the resident gas method, and we're drawing that on a graph. It has 4 phases, but we're really interested in phase 4, which is where we get that sharp increase in our nitrogen concentration. That sharp increase occurs because the dependent alveoli close, and those alveoli are poorly ventilated, so they never get diluted with the 100% oxygen that's been inhaled, so they always have a higher nitrogen concentration. The trick to remember is at that point where phase 4 starts, That's not closing capacity, but that's actually closing volume. So to get closing capacity, we need to know residual volume. And to get residual volume, we could do a body plethysmograph and then add it to our closing volume to get closing capacity. Then, along the same lines in the ICU exam in 2018, they were asked to define dead space and its components, explain how these may be measured, and the physiological impact of increasing dead space. The examiner report was pretty straightforward. It just asked you to outline the anatomical, alveolar, and physiological dead space. It asked about measurement techniques such as the Fowler and the Bohr method, and then it asked about the impacts of dead space being the impact on minute ventilation and the effects of an increasing arterial concentration of CO2. So to answer this question, you could just have a brief statement to say that dead space is wasted ventilation, the types being apparatus, physiological, anatomical, and alveolar, with definitions of each. You would then talk about how you can measure anatomical using your Fowler's method, and this is that same kind of graph we talked about with closing capacity, but here we're looking at phase 2 and calculating the area under the graph where there's an equal area under the graph below and above, and this represents the transition from anatomical to alveolar dead space. We can use the Bohr equation to calculate the physiological dead space. So the equation is the volume of dead space divided by the tidal volume is equal to the alveolar partial pressure of CO2 minus the mixed expired partial pressure of CO2 divided by the alveolar partial pressure of CO2. We can apply the Anchov modification and then use arterial CO2, but we would write in our answer that the caveat is that the Anchov modification can overestimate the Bohr equation because it takes into account other causes of an increased partial pressure. The main consequence of increasing our dead space is that the CO2 can't clear the body. So as the partial pressure of arterial CO2 increases, we get an activation of a sympathetic nervous system response. We get activation of chemoreceptors, increasing our minute ventilation. We get an increased work of breathing and therefore an increased energy consumption. This, along with an acidemia, can be lethal over time. And those are kind of the main points you want in that question. Before we go back to the ANZCA exam, there's one more question from the ICU exam that I want to quickly cover. In 2005, they were asked to describe the gravity-dependent processes which affect pulmonary blood flow. What changes occur when the pressure increases in the pulmonary vessels? The reason I want to cover this is a sneaky way of them asking you about the west zones of the lung. Sorry, this is a question from the ANZCA exam, but really what the examiner report states is that you really want to just describe and explain the west zones, explain the effects of west zones in other positions, and then finally explain the effects of an increasing pulmonary vascular pressure. So the first 2 points I think we've covered well. We know about how there's 4 west zones, and never forget West Zone 4. The effects on pulmonary pressures can be divided or thought of by looking at the effects of pulmonary pressures in the artery and in the vein. Now the lung is quite unique. It's overall a low pressure system, but it has the ability to compensate for high flows with high pressures. The way it does this is via 2 techniques. It can distend the vessels that are already in the pulmonary circulation, or recruit vessels to become open that were previously closed in the pulmonary circulation. At low lung volumes, what happens is that there's more recruitment of vessels, which makes sense because at low lung volumes you would think more of the vessels are collapsed, and if you're increasing the pressure, you're recruiting more vessels to become open. But at high lung volumes, that radial traction is already keeping those vessels open, so you get more distension occurring. So as pulmonary pressures increase, both pulmonary vascular resistance in the arterial system and the venous system decrease because it can compensate for higher flows or increase its flow rate with increasing pressures. And this concept of recruitment and distension is really important when we talk about pulmonary vascular resistance. We'll explore it in much more depth in our next podcast when we look at pulmonary circulation. But I just wanted to bring up this question now so that this concept isn't a foreign concept in the next episode. So we have 2 questions left, and this one is an absolute examiner's favorite. It was asked in 2021 second sitting, and it was discussed possible causes for the partial pressure of arterial CO2 differing from the end tidal CO2 in an anesthetized intubated patient on IPPV. It had a really poor pass rate of 27%, so I can guarantee this is going to come up in the next few years again. The examiner report was very clear on what they've wanted because they've asked this question 3 times now. So firstly, they want you to talk about the creation of the alveolar dead space and the normal values, and then make sure you discuss the common causes. So the way I think about the common causes from the examiner report is that I break it down into physiological common causes and equipment common causes. The physiological common causes are alveolar dead space and the differences in time constants, while the equipment common causes are all the things associated with the equipment lines. So to start this question, I would again begin with a simple definition of dead space, saying that it's wasted ventilation. The normal end tidal CO2 to partial pressure of arterial CO2 difference is approximately 3 to 5 millimeters of mercury. The main cause for this is physiological reasons, such as alveolar dead space created by West Zone 1, all the factors that can then increase West Zone 1. So remember, West Zone 1 is where the alveolar pressure is greater than both the arterial and the venous pressures. So things that can increase West Zone 1s are things like IPPB, decreasing venous return and causing hypertension, a shock state, a PE, are the main reasons that I would mention. Then we can talk about heterogeneity of the time constants of the lung. What this is referring to is the incomplete alveolar emptying. And remember the time constant of the lung, which is that the time constant is equal to the resistance times the compliance. So slow lung units like what you have in asthma or COPD are slow to expire out all their gas because their resistance is so high. So because you get incomplete emptying, you can't expel the CO2 out. So that CO2 starts to build up in your arterial circulation, leading to a wider difference between your end tidal and your partial pressure of arterial CO2. Unlike fast lung units that empty out quickly and get rid of all that CO2 for you. Then I would go on and talk about measurement errors. This is getting a bit ahead of ourselves because we haven't spoken about equipment and infrared analyzers yet, but things like confusion can occur of different types of gases because they lie on similar spectrums of how analyzers work, such as nitrous oxide and CO2, how water can lead to a higher CO2 reading, how there can be collision broadening occurring, which can broaden the absorption spectrum of a particular gas. Typically this occurs with nitrous oxide and carbon dioxide. We can have a ram gas effect, which is that the pressure in a big line drops as that pressure travels along that line. And a reason for this would be having a long sampling line. We can talk about simple errors like dilution by fresh gas flow, blockages in your sampling line or disconnections, calibration errors, or simply just too much water in the water trap or issues with humidification leading to errors in end tidal CO2 recording. So really, they love this question, but if you remember, you have to talk about alveolar dead space, you have to talk about time constants, and you have to talk about equipment and measurement errors. It's actually not that hard of a question to get right and get a pass mark. Then our final SAQ for today is from 2007, where we were asked to define venous admixture, briefly explain how venous admixture influences arterial O2 tension, and how inspired O2 concentration might affect this. So really, this question is asking pretty blatantly, do you know what venous admixture is? Do you know what the components of venous admixture is? So it's shunt and all the areas where there's VQ less than 1. Do you know that how you relate this to the ODC and the flat upper portion of the ODC and why its sigmoid shape is so important when we talk about shunt? Do you know how to quantify how much of a shunt there is using the shunt equation? And have you heard of the ISO shunt diagrams which show how much shunt there needs to be until giving an increased FiO2 has no effect? So if you have those points in your head, I would just use those as subheadings to answer this question. I would start off with the definition of venous admixture. So it's the amount of mixed venous blood that would need to be added to end pulmonary capillary blood to explain the difference in the O2 concentration between pulmonary and capillary blood and arterial blood. Making sure I write down that it's a theoretical calculated volume and not an actual amount. I would then go on and talk about how components of venous admixture include shunt and define shunt as wasted perfusion, and that there's anatomical and physiological and pathological causes of shunt, The common anatomical causes of shunt are your bronchial circulation, being 1% of your cardiac output, and your Thebizian veins being 0.3% of your cardiac output. Other causes of pathological shunt can be AV malformations, cardiopulmonary shunts, and so on. Then talk about how normally in a lung we have regional differences between VQ. There's heterogeneity between VQ matching, and areas which is less than a VQ of 1 are going to be added components to venous admixture. Then you can incorporate the shunt equation, which again is looking at venous admixture. So it doesn't make sense, but it's called the shunt equation. So it's a ratio equation that looks at the amount of blood that's shunted over the total amount of cardiac output. And for this equation, we need to know the content of oxygen in the pulmonary and capillary blood, the content of oxygen in the arterial blood, and the content of oxygen in the venous blood or the mixed venous blood. We can then incorporate this equation into the ODC and say that even if we get blood from the highly ventilated areas, this blood that is rich in oxygen is not enough to supplement the blood that gets shunted away. So in West, it has a nice way to describe this. Essentially, it says that shunted blood that bypasses the ventilated alveoli is never exposed to the partial pressure of alveolar oxygen. It continues to depress the arterial oxygen. Because of the shunt and low VQ areas, mixing of blood with the pulmonary and capillary blood creates an AA gradient. This is due to the shape of the oxygen dissociation curve. The flat upper portion increases the partial pressure of oxygen significantly, but only increases the carriage of oxygen by a little amount. So that is a combination of the best way I can describe a shunt along with the definition from West. Then to finish off this question, you would then go back and talk about the ISO shunt diagram. Once the shunt ratio is above 0.3 or in some texts 0.35, giving 100% oxygen to a person will not be able to compensate fully for a shunt. So that concludes our SAQs, and this has been a nasty topic to cover, but like I said at the start, I think this is one of those topics that you can really relate to clinical situation every day. Starting from talking about the vertical gradient of pleural pressure, we manipulate this every day when we put the patient from an erect position to supine to induce them, and when we put them in all weird positions such as lateral or prone or lazy lateral. So we're constantly tampering with a person's normal VQ matching. Along with that, we're giving them anesthetic agents that are going to be tampering with normal mechanisms that help to preserve VQ matching to be adequate. So this is just an added complexity. We're always dropping patients' FRC as soon as we give them anesthesia. So we're always bringing them closer to the point where their closing capacity is higher than FRC. With an aging population, most patients are going to have a closing capacity higher than FRC with any little thing we do. So we try to prevent this by giving the patient PEEP or CPAP to try to stop that small airway closure from occurring and maintain our FRC as close to normal as we can. We're always manipulating a patient's dead space. As soon as we attach them to any anesthetic circuit, put an oxygen mask on them, put an LMA down or an ETT down, we're introducing apparatus dead space. And this becomes really evident when we anesthetize the neonate population. You can see how a small licorice stick can be enough dead space so you can't get an end-tidal CO2 reading. Within dead space, we also looked at different ways to measure it, both anatomical and alveolar dead space, and we saw that how we measure anatomical dead space closely reflects how we measure closing capacity. Then we looked at shunt and venous admixture, and we introduced shunt to a patient whenever there's a degree of atelectasis. And a shunt is a very important thing to recognize because it's one of those leading causes of an increased AA gradient. And it's one of those things in a clinical setting, if a shunt becomes big enough, despite you increasing the oxygen concentration to 100%, your oxygen levels or your oxygen saturations will never increase. Both shunt and dead space have complex equations to remember. The shunt has the shunt equation, which is actually not calculating shunt, but it's actually calculating venous admixture. And dead space has the Bohr equation with the Anchov modification. Then finally, we looked at normal VQ matching in the lung and how there's regional differences. We said at the apex that the VQ is 3.3 and at the base of the lung is 0.63, and where the VQ is equal to 1 is at rib 3. Both perfusion and ventilation increase as we go from the apex to the base, but the increase is not equal between both of them. And how this VQ inequality, along with the shunt, along with the ODC, all tie in together and affect oxygen way more than they affect carbon dioxide. So that completes a mammoth podcast for today. Our next episode will be looking at pulmonary circulation. Until then, good luck with your studying. And just a reminder, I'll have that podcast 2 weeks before the written exam date with some tips and tricks. And we'll try to complete our respiratory topic by then as well. Thanks again for listening and your support. And I'll catch you next episode with pulmonary circulation.